lentes monofocais avançadas, lentes para astigmatismo, lentes trifocais. É um mundo de lentes que nós usamos na cirurgia de catarata. Cada cirurgião, nas suas apresentações, pode usar vários tipos de classificação. Devemos ter uma linguagem comum. É por isso que fizemos este episódio do OftalmoGPS, onde navegamos com clareza pelo mundo da oftalmologia. Hi, my name is Victor Maduro. I'm an eye doctor in the ULS São José, and you are here in another episode of OftalmoGPS. Today's topic will be how to use the IOL classification. How can we mix and how can you use several IOLs that you have to use in our surgeries? With me, I have Miguel Raimundo, that is our coordinator of CIRP. And welcome, Miguel, to another episode of OftalmoGPS. So, what brings us here?
Yeah, as you said, Victor, we are dealing in an IOL Pandemonium world. So, full breadth of IOLs are being released like pretty much every single month. And we are now on the verge of trying to put some order into the chaos. And to that purpose, I invited two esteemed, world-renowned ophthalmologists.
We have a premiere episode.
It's a double episode, in that sense. So we have Professor Filomena Ribeiro, which is the president of the ESCRS.
Okay.
And we have also Professor Mayank Nanavaty, which is an anterior segment surgeon from London. And he also serves as president of the British Society for Refractive Surgery. So welcome to you both.
Welcome to our OftalmoGPS.
Thank you so much.
And well, I think I'll start by asking Filomena about the article that she has published within the ESCRS Functional Vision Working Group, which pretty much tries to establish a functional classification. I know it's a daunting task, but could you try to summarize for the general ophthalmologist what did the paper achieve?
Yes, of course, and thank you for the opportunity to do it. Well, the reality, and you already mentioned this, right now we have so many different optical designs, different concepts of IOLs that can provide this functional vision that our patients need. The truth is, it's a little bit confusing for all of us how to choose and make the decision process to implant an IOL. Because the first consideration that we need to have is what am I providing to my patient, not the optical design and well, of course, the optical bench can for us to understand how an IOL works and the performance of the IOL, the profilometry, the MTF, and so on, but these tests, they are done in a very average model eye. It's not comparable with the real world. So at the end, the question of our patient will be, what can I expect with this IOL? And we need to have a way to translate this to the patient. So what we have done is going to all the report outcomes so far, 10 years that we have right now, different kind of IOLs, and try to understand if the outcomes, we can find different outcomes in the real world. This was done with a cluster analysis, and we could identify different clusters. And that is the real information that we need for our patients. So in a summary, we can have two different groups.
Okay.
One that provides partial functional vision, which is very well understood by all of us, and the other can try to achieve the full correction of this functional vision. In these two groups, they can subdivide in other three groups with different characteristics. So in the partial, we can have the narrow, which means provides a very good quality of vision for far, but nothing for intermediate and near. Then we have another subgroup that for the first time has a space in a classification, which is the enhanced IOL. And that one provides the same quality of vision for far, but can increment a little bit on intermediate vision. Doesn't mean that 100% of the patients will be without spectacles for intermediate, but increase the rate, the proportion of patients with this independence. And then we have the extent that goes a little bit more in intermediate towards a functional near, but is not yet the full correction. In the full group, what we have is the IOLs that can provide always a continuous line of focus above the limit criteria that we put for a good quality of vision, right? In all range of vision, from far to intermediate and near. And the other two subgroups, they don't provide this continuity. In some cases, some IOLs, they are not continuous, but almost the value that they have is very, very little. And the others, they have a more differentiate increase from the intermediate to near, which means really is not a continuous line. So this it's sometimes the names are difficult, of course, for us, and but we need to understand the concept, understand what this classification provide, and translate this to the patient.
Do you think that this classification is more adapted to the real patient's life? For you,
Yep.
it's the main objective?
Yes, so I think with this classification, we can finally say to the patient, this IOL is providing to the population that has under the same surgery, the same IOL as you, is providing these results.
So now to you, Mayank. So you talked about defining a framework so we can communicate between ophthalmologists. But what about the challenge of communicating these technological differences to patients? Like, how do you communicate to a patient the difference between a partial ROF IOL or a full ROF IOL with different profiles? How do you make that decision process with the patient? Could you share some tips on how you do it?
Sure. First of all, congratulations to Filomena and team for phenomenal work, which we needed. The problem was confusion between the ophthalmologists as well with these technologies which are thrown by the industry, like you say, sinusoidal depth of focus and extend range of focus, enhance focus. All these things are so confusing for ophthalmologists. So the functional classification, which ESCRS has now produced, is very useful for us to understand among ourselves. But what I find myself in my practice is these classifications can be daunting for the patients, because what they do is they go online and Google these names which we throw at them, and they get even more confused. So I make it simple for them. I said, well, actually, what do you want? Do you want to see for distance? Do you want to see for near? And do you want to see for intermediate? If you want to see for all three, then we've got options. And based on where your intermediate is, where your near is, we have different lens options as well. As you know, the different company lenses focus at different points for intermediate and near. And based on patients' demands, I would then give the options of the lenses which fit into that category rather than confusing them with any of these classifications. I think the classification is mainly meant for the doctors to understand what is the difference between the lens here.
Yeah.
An excellent point. So I'd like to proceed to a different topic, and again, now to Filomena, which is there's a growing, I would say, trend towards the implantation of called partial ROF enhanced, or more commonly called the advanced monofocal IOLs. Do you consider it to be the new baseline IOL, or in your practice, is it your new baseline IOL? Does it have any downsides that you can see? Is there evidence to support it or not?
Well, really, right now we have already some enough evidence to make that transition, to make these kind of IOLs to be our new standard for monofocal patient that we choose to be a monofocal IOL to be implanted. We made that publication trying to assess if we already have evidence enough to say that is a standard of care. The evidence is there. The only thing that we are missing is cost effectiveness studies. We this year the group of Rita Mencucci in Italy has provided the first study with these results, but still we need more of this. But yes, at least in my clinical practice, I already made the transition, and
I did that transition too. And you, Miguel?
Yeah, I did too. I think maybe there's a very minute group where I have some doubts with some lenses, which are patients who have like diffuse zonulopathy, where you feel the lens may not center that well. I'm a little bit fearful with some designs that decentration might not work so well with these lenses, but it's just a hunch, not evidence-based at all. But for the regular patients, I see absolutely no downsides, and there's the evidence to back it up. Surely.
It will be a gold standard nearby, I suppose.
No doubt. I think obviously, if the visual prognostics of the patient is not so good, maybe it's not an option, right? Depending on the
you
cost.
won't harm the patient by doing that. I think that's the issue. You share that vision? Is it
definitely. Actually, in the UK, all these the enhanced so-called enhanced lenses are coming into the public sector, which is the National Health Service, and that is an indication that actually this is more acceptable. Cost effectiveness is an issue, and especially when they come in the public sector, that is a major issue. But there is definite benefit of that. In fact, I'll go a step further. Actually, I being the cornea surgeon, I use these lenses for combined procedures as well.
I use them in DMAC and
such as DMAC, DSECs, and even post PK or post DARTs or something. So I don't see any downsides of using them.
I completely share that vision. Okay, now jumping to another topic, and now with you, Mayank. You've done a lot of research with pseudo-accommodation. Obviously, our viewers mostly are not aware of the concept, so I would ask you to catch them up on that concept, and see how you can bridge it to this reality of advanced monofocals or presbyopia correcting lenses. How can you mix together these two concepts for better outcomes?
Yeah, that's a good point actually, and it does actually make some relevance between the two subjects. Pseudo-accommodation is where patients can read and see without glasses. So the classical definition is 20/40, which is 6/12 or better for distance and near. Conventionally, people have identified one single factors. For example, astigmatism, pupil size. They didn't study a cohort of factors working together. And an ESCRS funded study called as MEROV study, which is already published in Journal of Cataract and Refractive Surgery, analyzes a cohort of factors working together. And there were 4 factors working together, which is small pupil size, low myopic spherical equivalent less than minus 0.3 diopters, total eye spherical aberration to be almost 0, and shorter axial length. So all these 4 factors gave an incidence of 9.6% of pseudo-accommodation. However, we took this further and put that into a statistical formula to look at which one of these 4 is more powerful in actually contributing to pseudo-accommodation. We found that negative spherical aberration between minus 0.3 and minus 0.5 is more important. Now, this is very relevant to the lens technology because most of these lens technologies will use negative spherical aberration. There are a couple of industry guys who are using positive ones as well, but majority of them use a negative one. So if you are using a negatively spherically abraded lens for this extended focus lens, then you need to consider the corneal spherical abrasion, which is pre-existing in that patient as well, in order to make them sit between, say, minus 0.3 and minus 0.5 later, once the surgery is done. If that happens, they're very likely not to need glasses.
Okay.
And with binocular summation, it'll be even better.
Okay. And another topic for you both. What do you think about monovision? Mini monovision, or our strategy? How do you choose the dominant eye? Which eye you begin to do the surgery?
Or does it still make sense?
Makes sense right now.
That's also a question, because I really think some of it started when we don't have good formulas and we started to err on the side of myopia, and the trend caught up for
but there is a
better
trend
near vision.
We have a trend in
and
Portugal.
How do you mix it with?
It depends on the patient's preferences. I guess it's same in your practice as well. If the patient prefers not to have glare and halo, with the full range of focus lenses, then I would go for the extended variety of the lenses and give them monovision. Now, if you are using an enhanced variety, which is not as strong as the extended versions, then my mini monovision difference would be around minus 0.75 or up to 1, based on where they want the focus to be. But if it's an extended version, then up to 0.5, because as such, they will give an 8 quality near vision anyway, even without mini monovision, and binocular summation will give you a line better. But if you are having minus 0.5 difference between the two eyes, then they might be spectacle independent completely. With the dominance check, I use a normal test, the finger test or the stick and the pen or whatever they can use in the clinic and identify the dominance.
And you, Filomena?
Well, I think there is also a space for that, and we know that patients that are used to have this difference between both eyes, and they take advantage of that, and they would like to stay like that. They sometimes they are very clear on that.
I have 48 years and I use my mini monovision, so.
So then, these kind of patients, I think, is a good indication, no doubt about it. When we start to think about these new type of IOLs, of course, we need to always think about binoculary. But these designs, and at least the most complex, they are not so tolerant to residual refractive error. So we need to be clear on that. If we are choosing a IOL that intends to correct the full vision, we should target emmetropia. Of course, then we have the extend and the enhance monofocal IOLs that they are more tolerant to these residual refractive
error. If you have
error.
like peaks of vision and you shift it, you'll mess up with the focal distance.
Exactly.
So emmetropia is relevant.
So I'm not so kind of make it from this plan from the very beginning.
Okay.
But if after the first I see that the patient would need a little bit more, I can maybe target the second eye in a different way. And they have more functional vision. But yes, it isn't. I think emmetropia is a very good concept, and we are refractive surgeons, right? So we like it.
Okay.
Yeah, but I agree with Filomena that correction of emmetropia is important.
We study to have emmetropia and then mix again.
Yeah, and astigmatism correction is also very important in that line. So I correct anything above 0.5 diopters with toric lenses.
That is important to say that. The astigmatism correction is very important to.
With any of these strategies, whether it's distance emmetropia or mini monovision.
Astigmatism kills results.
Really.
Kills the refractive of the IOL. It's awful.
No doubt. The problem we have right now is the very small astigmatism. That is the problem we have.
That we talk.
Hard to measure, hard to correct, hard to calculate.
So where do you think that will be in 5 to 10 years with IOLs? What do you feel about that?
Well.
Tough question.
Our hopes always go to the accommodative IOLs, but we cannot see it right now in a level that we can say very clear that will be in the next future. Of course, there are very good developments in the tolerance of dysphotopsia, these new concepts of IOLs. They really have improved in dysphotopsia. When we talk about that and the fear of having to explant an IOL, we don't see it so now. So they really are getting better and better. Okay, we have also the IOLs that can change the refractive index and so on. Could be a good option to have this margin of error to correct. But
I think as you say, Filomena, we got light adjustable lenses at the moment, which is a very good technology in my opinion, but it is still clunky. because it requires a machine and the patient coming back in 6 weeks to adjust the lens. I think it has to refine. And in coming 5-10 years, we might see that patient might be able to change that on the phone, for example. This is just, assuming things, but I think it will improve and patient will be able to change the focuses of each eye in
I think
future.
adjustable lenses will make a lot of sense, and
Yeah.
maybe it's a thing that it's coming in the near future in a refined version because we already have it.
Yeah.
For
Yeah.
the little astigmatism residual.
Yeah, like to handle
Yeah.
to handle the little stuff, and I think that will be a big.
But the main problem which we still face is the post-operative dry eyes,
Yeah.
especially in full range of focus lenses patients, and that will last for 2-3 months. And the fluctuation of vision is the main complaint.
Yeah.
I think that needs to be mitigated as well.
Yeah, that will be another whole episode. So
another
we'll have
theme
that in mind.
in mind in the next episode.
Okay, thank you to you both. It has been a phenomenal
Thank you.
conversation. Obviously, we don't have infinite time, so we have to wrap this up. I'll take the message home to our viewers that really we are in a new era where we have the tools to classify IOLs based on evidence in a way that makes sense beyond the marketing push that the companies do. We also have new ways to think about refractive strategies, so it's no longer monofocal and multifocal, so we have much more tools at our disposal. So it's definitely an exciting time to be a refractive surgeon. And thank you, Vitor. I'll
Thank you,
pass the
Miguel.
baton to you now.
Thank you to you both. It's for
Thank you
us
so much.
pleasure for OftalmoGPS to have you both here. For us,
Thank you
it's
for
very
inviting.
important to have both of you here. Obrigado por terem assistido a este episódio. Foi um episódio super importante. Tentámos pôr alguma ordem no pandemónio que são as lentes intraoculares. Esperemos que tenha gostado. Já sabe, este episódio vai estar disponível nas plataformas habituais, no site da SPO, no YouTube, no Spotify. Queremos imenso que faça likes nos nossos episódios, que subscreva o nosso canal, que seja uma partilha diária connosco das suas opiniões acerca dos nossos episódios. Este é o OftalmoGPS, onde navegamos com clareza pelo mundo da oftalmologia.